So it goes a long way to help us communicate better, and also in the long run also protect us during our practice. So please, okay, like I said, consultation skills are not just communication skills. It's like an umbrella, it's like an umbrella topic that encompasses communication skills, data gathering skills, decision making skills, as well as the use of computer in consultation. So we'll be taking communication skills. Communication skills actually form the vast majority of consultation skills. So a lot of skills in a lot of the skills we are going to be talking about are actually communication skills. Then we now mention the other components that make everything together as consultation skill. So examples of those skills that are important for us to know are active listening skills, understanding empathy and compassion, agenda setting, which also means exploring ICE, which is an acronym for ideas, concerns, and expectations, and also the PSO, which is psychosocial and occupational aspect of the patient management. So other communication skills are signposting and summarizing skills, explanations, especially skills that have to do with breaking bad news and also explaining risks to patients. Also, among the communication skills is medical analogies, how we explain the things, break them down to patients' understanding, the kind of languages we employ to make sure that these usually medical jargons are brought down to patients' understanding. So also available for us, vast majority of scripts and phrases for us to use in consultation. So people have come up with a lot of phrases that will help, that will ease you freely into consultation, which as one progresses in career, you can also develop your own. So communication skills are so vast. The ones I mentioned are the ones who would be concentrating on. Others are like handling conflicts, negotiation, and persuasion skills, using non-heterosexual bias in language, especially when it comes to do with LGBTQ. I know that some people will say that, okay, we don't have much of that problem here, but it's slowly it's going to come. So, and also some of us are going to practice outside our community where we are currently. So these are some of the things that we still have to be very conversant with, so that we don't go out there and people will start wondering from which century is this person coming. So among the ones that we'll be talking about today is active listening skill. So it's actually a technique that helps to develop our ability to listen. So when we talk of listening, it goes beyond hearing. Hearing someone is, when you just interact with the person, you hear what the person is saying. Whether you internalize what the person is saying, you cannot, people cannot really adjudge. But when you are listening or actively listening, it shows that you fully concentrate, you understand, and you're able to respond and also remember what is being discussed in the communication during the conversation. So it is a technique that is used by many professionals, and also it's actually valuable in our day-to-day life. Most of the problems that people have, even in their relationship, they talk of, you are not listening, I'm talking, you are there, you're just quiet, you're just silent. So when people actually listen to us, we know that they are listening. Whether they are silently listening, there are ways by which that this person is listening to us. So this is also, active listening is also opposed, though it incorporates other aspects, other methods of listening, which are reflective listening and also empathic listening. Empathic listening. So, talking of active listening skills may establish flow to a dialogue rather than close-mindedness. So the key ingredients for good active listening, like we said earlier on, the person is paying attention, the person is not judging, so the person reflects on so far, If you don't understand what the patient has told you, you clarify some things with the patient, and your own conversation that you had with the patient. The patient told you, okay, they have headache. So you're able to go from that, expand the conversation, able to get some other information that the patient might not even know that they are supposed to provide. So, and everything that you discussed with the patient so that you can achieve, a final decision. Make your thoughts known about the discussion that you've had with the patient. So, as proposed, there are actually 4 special skill areas that can help us to develop our ability to listen attentively. So, when the first is wait time. I know quite a number of us, because mostly the clinic is usually busy. When the patient come in, you want to start, the conversation, start saying things, talking and all that. So, but ways by which we can develop listening attentively is to wait, let the people speak. We should allow them to speak. Then we should try to be present in the moment that they are speaking. Not that maybe the patient is sitting down, is talking, and you are arranging, okay, what the person is saying, you don't even have time yet. So while they are talking, you wait, listen to them while they are talking, to show that you are listening or you're in the moment. Like, okay, maybe nodding there. Okay, go on. That's to show that what the person is you are internalizing what they are telling you. Other non-verbal ways is maybe, eyebrows and all that. So, and also talking. Another way that you can also do is to, pay attention to cues, how the person is saying it. Is the person moody? Is the person saying, looking, having an expression of something else? You're asking the person and is looking confused. So those are ways and develop our skills to listen attentively. There are some roadblocks that have been noticed to use our listening skills. Judging, maybe a patient comes in and is talking, you are making or non-verbally, you are showing the patient like, okay, head is not supposed to be how it is, outrightly, just from the first. So name calling or labeling, like someone has, the moment the person comes, you're referring to the person as, diabetic food, instead of, names or something, you're using their disease to call them, or okay, referring to them like that. So also, you start telling the patient what you have and all that. Obviously, we started like, okay, so and also even some excessive can also mean that, okay, you are actually not listening, especially when the person does not even feel that they are worthy to be praised in the phone. So also, suggesting solutions so early in the conversation, haven't even exhausted everything, of the consultation time. Of the distance, they blocks to active listening. So also the person's concern, like, okay, even if you are not attend to those concerns at the time of that presentation, letting the person know that, okay, what you are saying is not important. You are rationalizing what they are saying, or trying to things to make them feel like, okay, what they are saying is what. Of course, there are sometimes maybe you don't have time to address all the issues that they presented, but you can acknowledge that, okay, this is happening, address it at a later time. Or maybe you, of course, we are still going to go to that. The ones that are more, acknowledge that they had told you this, and this is just a quote from this is Ian McWinney. So that learning active listening, you can learn to be a better listener. So, but learning it is not like you adding more skills on how to do this, how to do laparotomy and all that skills that we know, but more of, things that interfere with our listening, our preoccupations, or how we respond to what we hear. So learning to train our emotions when we are faced with, certain circumstances that are not usually normal to us. So it is more of peeling away some, because already we know how we know how we attend to patients. Some of the things we are going to talk about, these are not actually supposed to be like this. It's like you are unlearning some of the things that you do when faced with certain circumstances. This, okay. So this we just active listening. Of course, there are vast lot of information to improve our active listening skills. This presentation is just like do everything. It's actually a very huge presentation. So the second is agenda setting. So this agenda setting, remember we said we are talking about which is part of consultation. That setting is also part of communications. It's where the clinician elicits the full set of concerns that the patient has in the patient's perspective. So then you use it to form information to prioritize and negotiate which of the issues that are most pressing and the ones to be dealt with, or the ones that needs to be deferred to a subsequent visit. We know that our clinics are usually very busy. So it's just like when we talk of presenting complaints. So basically that's what it is here. So what are those concerns that the patient has? Sometimes they can have thousands of concerns. So like judging which of these that you will handle at this present time is limited. So that's basically agenda setting. So why do we want to agenda set with? It helps to reduce uncertainty. For instance, okay, and also allows us to effectively use our time. Like sometimes patients are of the habit of raising in the consultation. Maybe when you're almost done with the patient, that's when they will tell you something that will erase everything that you've been doing since from the beginning. So it helps as an to get us to the point, the important information that we need, and also what we want to discuss at that visit. So it also encourages and mutual partnership. So how do we, strategies? First of all, we have to, of course, listening is coming in again. We have to listen to the first problem. So because if you interrupt patients, they tend to, go back again and, start. So we listen to them, we summarize the problems, then check what you've heard, like checking with them, is this what you have said? If did I get you right? So are problems, verbally or non-verbally. So then we now ask for other problems if there are that the patient wish to discuss. So this will help us to reduce any late comma of problems or information that the patient. Still any information that you wish us to address today. So now after getting all the information, we prioritize them, then we negotiate which one that would explore that particular occasion. So while agenda setting, it is important for us to take note of ICEs and PSOs. So the ICE is acronym for ideas, concern, and expectation. So the idea is what the patient is thinking or is feeling. The concern is what the patient is worried about. Okay, let's, for instance, now the patient has a headache. The patient feels like they have a headache. patient is thinking, okay, now that I'm having headache, is it possible that I'm about to, is it possible that I'm about to die? I've ever seen someone that has had headache and, had stroke, all those kind of, the concerns, what worries the patient. So then the expectation, usually when they come to us, they have certain expectations that they want at the end of that consultation. So there are certain ways that we can, ask some of these questions. And also while approaching IC, it would be preferable to do that not too early in consultation. So there are lots of scripts, phrases to go about this, some of which I might not be able to discuss here, but the link will be there so that at the end of the day, we can go through some of these phrases on how to phrase some of these questions so that patients don't get offended. Some patients are so woke now that they even know some of these our terms of skills, and when they come, they'll be like, okay, you are doing me this, you are doing me that. So it's actually a tougher world for this century practicing. So going to psychosocial and occupational exploration of skills during consultation. Usually the medical problem, the problems affecting patients have psychological, social, or maybe occupational affectation. So these are some of the things that we would like to also explore so that you can properly set what it is that it's very important for you to discuss at that particular visit. For all we know, it is the psychosocial or occupational aspect of the thing that actually made the patient to present. And if you are unable to get to that point, so patient will not office feeling getting what they actually, like we've already discussed, the mental well and the disease is presented. The illness is what expectation, how the disease entities, both their social life, the work life, and otherwise. So having explored all this, I've said that, okay, you've attended to these patients holistically, or you have used the patient care method in attending. Another communication skill that empathy and compassion. Empathy is said to be the ability to and share the feelings of another. So the aim of empathy is to help to understand of what was discussed, and also to appreciate that you are sensitive. So there are ways by which one can. So empathy. Okay, I think there's sometimes empathy with sympathy. In sympathy, is feeling, but you don't actually there is no element of okay, you have experienced or you've understood what is going through, even though you acknowledge that they are going. So so among the empathic statements are supportive comments that especially link the I of the doctor and the you of the patient. It's actually a statement by, so the I of the doctor and the you of the patient when empathy has. So for example, when you say, I can appreciate it is for you to talk about this. So you as the doctor, then the you patient. So in this way, you and the patient have sometimes saying this to a patient one way to lift from them what of what they think they are going through. So we talked about the verbal of showing empathy, the I and the. Then the non-verbal ways of communication, like showing facial expression, the proximity, and the tone of your voice even. talking, at some point you lower your tone, you're empathizing with the patient. It shows that to their predicament. We put up a little story here. We had an experience sometimes back, and accused me of laughing when him the diagnosis of his son. I didn't even know I laughed, or maybe I was happy that the child has type 1 diabetes. I was like, okay, and this was reported close. Came and told me that the way I was doing, like as if that the child has type 1 diabetes. I was like, okay, so whatever it is that I had done, consultation, obviously I haven't shown empathy, verbally or non-verbally. The cues have shown that, okay, this is an information that I'm giving the patient that is actually a traumatic in the whole course of the patient's life. But the patient is not even, the patient still has time to look at whether I am live. So that is it. The way we tell patients what we tell them, showing them that we care goes a long way. Sometimes that when they come for consultation, they already have no, they just want to know that someone feels, is willing to show them that sense of. So, like we've already, this empathy and sympathy. So you are from out position, whereas empathy, like you. So we're actually discussing empathy, and so compassion actually goes than empathy. You have empathy, and now you are willing to alleviate or reduce the suffering of. So that is where compassion goes a step. So it's what they actually call empathy fatigue. We see a lot of patients that that work with chronically, they are on your head every day. This one with sad stories. So physicians have been said to have what we call empathy fatigue, because you are always trying to put in the position of the patient, feel for them, just like some actors or some of might read about the life history of the character they are portraying, so that character and bring out the life of the character. So stressful when a physician has to be acting that every time. So they even go beyond, they hurt you yourself, they beyond act, and it actually traumatizes. Empathy can actually lead to burnout, physician burnout. Whereas compassion, they said, is it has like a reserve. So you are there, you have felt with the patient forward, and you are ready to do something for the patient. So I would just like to here. Perhaps this is why some people prefer to practice in a place where they want to see. It's not just you diagnosing, but when you diagnose, you want to be able to do something to help that patient. Story came at the end of the day, oh, you don't have anything to work with, and the patient dies on your head. So people that practice where they have everything they need to make better impact in patient lives, perhaps they have better job satisfaction than in other places where they just virtually just hear patient stories and there is nothing much you can do for them. So I think that is where that is just my own chip in here. So among the communication skills is signposting, like we've mentioned earlier. So signposting is like a transitional statement that allows us to signal that we are going to change the direction of the conversation. Of course, as the physician, or as the physician that is versed in consultation skills and communication skills, it doesn't mean you are just going to sit down there and just allow the patient to talk and without guiding the patient as to where you want to be at the moment. So when you want to signal that, okay, now we have explored the history of this, of that, let's move to this history now. So that is what we call signposting. So when you signpost, it helps, it helps to, it can also help, to move from open to closed questions. You ask the patient before, what is your complaint, for instance, and the patient goes, said all sorts of things. Now you want to zone into one particular, complaint, so that patient gives you a direct answer. So when you signpost, you can let the patient know, okay, having gathered all this history from you, so I would like to ask this particular thing about this particular thing, so that at that point the patient knows where you both are. You as yourself also know where you are at what point in the consultation. So it helps to move through the natural steps of patient management up until treatment. So it also helps in explanation and planning. At any point, it's natural. By the time one is, it's something we do even without unconsciously do, even without paying attention to it. It's just that, reminding us how we do it now. Sometimes patient, okay, you are already, at the point of treatment, talking of the drugs and all that, and patient is still thinking you are still exploring. So because you haven't carried the patient along, now we are at this point, so the patient doesn't go back and start telling you that, okay, my grandfather is doing this, is doing that, when you're already trying to discuss treatment plan with the patient. So with signposting usually come summarizing too. So it's very pertinent for us to be able to summarize every information that we've gotten. So there are broadly two types of two kinds. Usually we can summarize at the beginning or middle summary. Like patient, you are like halfway into consultation, so you take your time to tie up some information that you've already gathered together. So especially if a lot of information had been given, so that you are able to be very sure, the patient is also sure that you all have gotten this information correctly. So, and also end summary, that happens naturally at the end of consultations. So all the little packages, the little summaries you've had here and there are neatly tied together, and they'll form your decision-making stage. So the importance of summarizing both to the doctor and patient. Usually for the doctor, while you are summarizing, it helps you to put your thoughts together, and you're able to hypothesize and naturally in your head begin to problem solve. So, and also you can communicate to the patient that, of course, I have understood what you have said so far. And it also helps to clarify any areas that are gray areas that you are not very sure about. For instance, having come this far, so I want to believe that this is what we have, the information we've been able to gather, and all of a sudden the patient tells you that, no, that's not what I have said. So summarizing also have a lot of benefits for the patient. It allows them some space to think, and it also shows that the doctor has fully understood what brought them, and it also gives them opportunity to correct, like we already did. So another very important communication skill is explanations. Most often than not, we complain that patients don't understand what we say, or patients just, you tell them something, you think they've understood you, they just don't understand what you have said. And even while you are giving the information, at that particular visit, you'll be surprised that if you try retrieving that information from the patient, you are unable to, because perhaps the patient just does not get it. And some patients feel like they don't want to be perceived as being a fool or stupid, like they can't, take in little information. They wouldn't even tell you that they don't understand. So now, part of the problem of miscommunication usually is how we explain things to patients. A lot of areas that we need explanation. Naturally, in our patient, we need explanation. We need to explain our examination findings to the patient. When I examined this, I found this, and that. You have to explain it to patient. So also, if there are any investigations, the diagnoses that you want to make, why you are thinking of what you are thinking, you need to explain to the patient, and patient has to understand. So also the treatment plan, if there is any referral, why you want to refer the patient needs to know. You'll be shocked that you refer a patient, and the patient will tell you that they don't even know what they have, and they have no idea why they were referred. That is what the patient will go out of that consultation room with. So usually when trying to explain to patients, there are anything that we need to explain to patient, it's very important to keep the explanation very simple. There should be no medical jargons, and it should be relatively concise. It shouldn't be like a lengthy story, that patient get lost in. We should be able to tie the information together and be relatively concise, still containing the vital information that the patient needs. So, and also if we have a lot of information to explain, we can do it in bits. Sometimes some of these explanations don't even have to happen in one sitting. So, and also we should at interval check for patient's understanding. So having said this so far, would like to know if, what you have said, the patient understand. So also is to help, it will also be nice to watch for non-verbal cues that patients give. You are explaining something, patient is trudging and all that. So, and also while explaining, it's important to use patient starting points where possible. For instance, the patient comes into the consultation room, you ask them about particular information, whether they know they have a complaint, they have a chest pain or something like that. Perhaps they've been having the chest pain for long. They actually know why they are having the chest pain. So what do they know about this? They already have some information with that. So while explaining your diagnosis or the treatment plan with the patient, it won't be wise to go back to the information that the patient already has that are correct. Otherwise, is to use the patient's point as your starting point for explanation, chipping in the previous discussion. Okay, when we talked about chest pain earlier on, you mentioned this, and that. This is what happens, and this is this. Just from where the patient, understand. There will be no need teaching someone what they already know. So also, things that help in explaining things to patient, a lot of things like leaflets when appropriate, and while giving leaflets to patient, it's very important to know what is inside the leaflet. Sometimes the leaflets themselves contain ways of explaining those things in simpler. So knowing what is inside, not just randomly just sharing leaflets, and at the end of the day, patient will be like, okay, doctor, please, what is inside there? You'll be like, okay, what is that too? So giving, and sometimes even using the leaflet to explain to the patient. So okay, basically that's about explanation. So another very important aspect of explanation is breaking bad news. Unfortunately, most of the things we do in the hospital has a lot to do with bad news, whether it's an diagnosis or anything at all, both acute or chronic illness. So the ways in which we break bad, not necessarily deaths in practice. So we have to, learn some of these ways. They're actually just a micro skills. This table is showing, two separate, one by Kai, the 10-step approach, and the other one is the spike, which is by Bill et al. So the approach, you can see, the approach for early in death, in scenarios of death, but able to our day-to-day clinic activities. For instance, preparing the patient, if it is the patient or a dead relative, preparing the stage to, receive the. Is the person standing? Do you think the person will hearing this bad news? So the person should rather sit, to be close by, or to be close to be see the bad news. This is what we should ask. Information do they have already? Any information about what the situation is, and also to know more about it. We'll be surprised that some wouldn't want to know about some things. So, and also to after giving the information that we want to give. So the information that we want to give, we should demonstrate some sort of knowledgeability in the information, so that we'll be able to address the patient's concerns, and also to summarize the further plan. For instance, while explaining a new diagnosis to a patient, intend to do moving forward. So and also to offer the patient that the available the support systems that are available, that the patient can access, loss, emotional distress. So we break bad news. It is very important to check our facts. The diagnosis, do we have the right diagnosis? If it is main message of death, are we talking? So then all diagnosis, like we said, we should understand the diagnosis. We already have made up our mind as to the next. Not that after telling the patient, then the patient will be like, okay, then unfortunately we'll be asked. So having all that in our head already as to the next line of action will help the news to naturally. So like we said, it's very important to be sure that we have the right. It will be very disastrous to give news to the wrong patient. No matter how it's very, very disastrous. So let me quickly chip in this here. There was a colleague, someone that told me a story of how they went for a job interview. The next, they were told to come for a medical checkup, and only to be called that, his result is out, so he should come in to check because he has hepatitis B. He said he felt so devastated. He was like, by the time he got there to collect the result, they gave him the result. Lo and behold, it was negative. So they had to, take him in to meet the doctor and everything. But the person whose result they had communicated to this young man, is there somewhere. So it's very important, to check our facts and be very sure that the right person is receiving the right information. So also the support system is very important. There are some information you wouldn't, especially, looking at the circumstances, you wouldn't even want to divulge it if there is no support system there. So next slide, please. So with the explanation skills, also related to it is explaining risk. How do we go about explaining the risks to our patients? Unfortunately, most of practice don't offer, most of the interventions we do not offer 100% accuracy. So we have to let the patient know that there is a risk of this and there is a risk of that. So how do we go about, communicating this risk and explaining it so that the patient will understand comprehensively? So these are some of the tips to help us to explain risk. We should avoid using terms like this is common, this is rare, and also to avoid using percentages. Instead, we should put figures in context. For instance, we want to talk about 2%. We should let the patient know that 2 in 100. If, for instance, it's a big percentage, like 5%, we can let the patient know that 1 people. For instance, maybe somebody's cardiovascular risk, coronary heart, vascular heart disease risk is, we can let the patient know that this is 1 in 20, this is 1 in 25. That makes more sense usually to patients. Also to use pictures, diagrams that can help patients to know what their risk and their chances are. Some patients don't follow through with their treatment because they feel like, they don't know what the risk of not doing that is, or what they are, what they are playing with. And their thoughts or their misinformations can easily be addressed when we let terms in terms that they understand what if they choose not to adhere measures. So among the communication is also usually mentioned medical analogies. Analogies are just ways in which our medical, jargons to patients. Some the patient common things around to build, to explain this to the patient while comparing them. And also while there are certain things we should ensure to put into place. We should be able to verbalize it easily. No need of using an analogy that even you yourself you don't understand or you can't even pronounce them. So they should be short and simple because we are trying to explain it, to simplify things. So it shouldn't be even more cumbersome than what we are trying to analyze. So also we should try to link the analogy we are making to the disease condition that we're trying to explain, such that it don't look like you're just gisting with the patient. The patient understand that which one is representing this at this particular point in time. It helps them to understand better. So also using, things, borrowing words from their occupations, things they easily understand, things that and everyone knows what they are. So using those things to explain, to make analogies, there will be no need, it won't be of any, any use for us to use an analogy that the patient doesn't even know what we're talking about. So there are lots of scripts and phrases, like I've already mentioned, almost or everything that we've discussed in communication skills. It's so well developed that there are, a lot of scripts out there that can help us, that we can master. They will help us to, naturally communicate with our patients better. And as time goes on, we will also, develop our own, maybe based on, or contextualize some of these phrases, depending on which part of the consultation you are. For example, how do you feel about that plan? Or what questions does it leave you with? We can, ask questions, communicate with our patient, everything that we've been discussing, that we are listening, empathy and, compassion and all that. So we've looked briefly at some of the communication skills. Like we've said earlier, communication skill is just a big subset of consultation skill. The others are data gathering skills and, decision-making skills. So talking of data gathering skill as a consultation skill, basically it's just how we get the information that we get from the patient. What are the sources of those information? Usually we get our information from history, the examinations we do, investigations, and we remember the patient's ideas, concerns, and expectations. Then also the effect of the illness on the patient. So these are usually, the ways that we gather the data. So gathering this helps us to tailor our management to individual patient. Because ordinarily when you talk of management of a disease condition, so you go history, examination, investigation, management, but incorporating ICEs, PSOs tailors that management to that particular patient. So then you would have been said to have seen the patient holistically and also had employed patient-centered care method on the patient. So the other aspect of consultation skill is decision-making skill. Of course, the whole essence of the consultation is to make a decision, to be able to start the process of problem solving. So there isn't it's all about taking our thorough history. I mean, the stuffs here, basically. What we're supposed to do in terms of maybe a focused examination are necessary. So these are the things that helps us to decision. So the art of making and decision, two systems have been. We have the fast thinking and the slow thinking system. So the fast thinking system generally would call spot diagnosis, or it's situations. You see something on the spot, you act on it, you decide this is what it is. Or maybe somebody comes, ruptured ectopic pregnancy, spot diagnosis, emergency. So this one, knowledge you already have about this certain circumstance, so you are able to act immediately. Usefulness of fast thinking in decision making. So the slow is the one that helps us to calm down, make some right considered decisions, take into cognizance. Some decisions are not so easy to make in terms of patient management. You want to put in the nitty-gritties, think of this, okay, this patient would have benefited of this. So it helps you to have a well-rounded, come to a decision that is well-rounded, that you can justify at any point in time. Each and every one has its merits and demerits, and they should be employed or deployed at the specific or during at the point that they are needed or they are useful. It's not like, okay, you are always having fast thinking. It's only fast thinking, you operate on only fast thinking. You can make mistakes. It can lead you to making mistakes. Just see a patient without thinking thoroughly what you want to do for the patient. If it isn't an emergency situation and all that, then you just rush into a decision that you might want to retract later. So now the ability to move in between these two styles is what makes a good GP with good decision making skills. So this is also an acronym that helps us to decide what to do. We basically how we go through our consultation skill as well. We reassure the patient, the advice, the prescription. What kind of prescription are you giving? You want to still have the patient in contact? Sometimes you give short prescription because you want the patient to come back and all that. So referral, observation, so prevention and health promotion. So these are some of the things that we do when the decisions that we take in patient management. So of course, there can be diagnostic uncertainties. One can never know everything completely, be sure that okay, this is this. There can be certain circumstances that there's a bit of uncertainty. So usually, according to Butings et al., he suggested that he or she, I'm not very sure, suggested 4 strategies to deal with diagnostic uncertainties. Your gut feeling. That gut feeling is very important. If it is telling us that something is wrong here, we shouldn't dismiss it. Because usually from training and all the lot of information that one has gathered, there are some things that if they don't feel right, they are just not right. So also the use of diagnostic algorithm, there are quite a number of them. If it is not this, then use this. If it is not that, do that. They come in tables, charts, diagrams. So that can help. Then also planning additional tests. What other investigation do we need to deploy here so that we can attain, have a better level of certainty? So, and the use of safety netting. So safety netting as a way of maneuvering our ways in diagnostic uncertainties was actually introduced by Neighbor, and the term was considered as one of the compounds of a good consultation. Like we said, you can't know everything. So he described that safety netting, he described it as creating a contingency plan and implementing procedures to ensure that the strategy is effective and that the patient is safe in any, unforeseen eventualities. Now you have a plan that you want to follow. Okay, in case something else comes up, this is what we are going to do. And communicating this to the patient so that the patient is fully aware of this. This is what we think is happening here. This is what we plan to do. In case something else comes up, this is what we are going to do. This is what you should do. So he defines it as encompassing 3 things. If I am right, what do I expect to happen? For example, this is usually used a lot in pediatrics. For example, like, okay, maybe if I am right with what we have done today, the fever should be gone in 3 days. Okay, how will I know if I am wrong? For example, maybe the child still has fever after 3 days. So this is what you are explaining to the mother or the guardian of the child now. So what do we do then after the whatever the result is? For example, you make an appointment for me to see that child after 3 days. So this is an example of safety netting, such that you are able to cover yourself. It's not just practicing safe, also avoiding litigation, because everything you discuss is going to can and might be used against you in any particular point. So the last but not the least of our consultation skill is using computer in consultation. We are in the computer age, no doubt, and it has a lot, vast, it has revolutionized everything. But unfortunately, it is getting in the ways of we and our patient as well. In as much as we, recognize the advantages of computers in consultation, better access to information, ability to record things, retrieval, and all that. So we've noticed that patient also the attention of the doctor can be diverted to focusing too much on the computer, not even looking at the patient or not making as much contact as is necessary, because one is busy typing things into the computer or maybe checking some information and all that. So at the end of the day, it's patient gets lost or they feel like they haven't been attended to. So also there's an issue with confidentiality problems. Some patients feel like maybe you are recording them and all sorts of circumstances. And I'm very sure that even in Nigeria, some patients believe that when they come to your office, you shouldn't be looking at anything, even your phone, computers. No, you should just be saying things from your head. You open something. Okay, so the doctor had to even go and browse their phone or go and open computer before they knew what was wrong with me. So these are some of the things that, without properly educating the patients as to why we are doing what we are doing, they would go out of the consultation room with all sorts of funny ideas in their heads. So now it's very important to maintain rapport while we are still using the computer. We should maintain and sustain rapport with the patient. So, for instance, the positioning of the computer and also the posture, or your own sitting posture as well. Perhaps instead of facing the computer, or the computer facing, instead of facing the patient, the computer can face, and patient can be by the other side of the desk. Because if the patient is facing you and the computer is in between you and the patient, it becomes very difficult. So these are some of the ways by which patients will still feel engaged. So also during the time of typing things or checking information, we should ensure that it's not the time when the patient is talking. Like maybe the patient is saying something and that's when you are doing things in your computer. It should just give the information. It should just give it like, okay, you're not listening to the patient. So that's what some of the problems there. So also involving the patient as well. Quite a number of times I've had to turn the computer to face the patient. Okay, this is what we are talking about here. This is this is that. Or maybe even the test result. Some were receiving results so that they know what you are doing on the computer. It's not like they just came and you decided to just face computer. This is your test result I'm going through in the computer. You can see this is this is that, this is that. So explaining to the patient what the computer is being used for, why the computer is being used, will go a long way, especially when they see the screen and they see what you're doing. Sometimes there's some information we want to show them, maybe a chart that we have on the screen that we want to show them, turning it to face them, let them see those things, read from it. So it's like you are engaging. So it's like three people in the consultation now. You, the patient, and the computer. So you are all engaged in that consultation. I think this takes us to the end of the presentation. My reference, this has actually been very useful. Most of my resources were from this site. A lot of things to books that one can download from the site to help in further development of this very important skill, the consultation skill. Thank you very much for listening. I'm very grateful. I'm sorry for taking so long. I didn't plan to take this long.
Thank you very much, the chief admin, for this wonderful organization. And I also appreciate the presenter for the excellent presentation. Thank you very much. My own comment is just like getting some points for us as a take home, because this topic is actually very, very important. We've noticed, at least from the few years I've practiced, I've noticed from myself and even from colleagues that we don't communicate properly with our patients. Maybe due to patient load, I don't know. But it has been shown that proper communication actually reduces the rate of litigation and also the rate of violence against health workers. Because when patients are being carried along about their complaints, about everything that's happening to them, they would feel much appreciated, even if at the end of the day, what they get out of it is not what they expected. They will still feel more appreciated. And also, part of what I also want to, or want us to take notes from this presentation, is the ICE method, although at times we call it 5A. That is getting the patient's perspective of what is wrong. Because at times, that may even lead the clinician to the diagnosis, as in asking the patient about the idea of what is wrong with the patient. So the current medical practice is changing from the paternalistic method to the consumeristic method. That is, in years before now, is always the doctor is always right. Doctor will just be making the command, do this, do this, do this, do this. But now it's more patient-centered. We have to incorporate patients in everything we do in their care. I think those are just my comments. Thank you very much.
Thank you very much for that comment. I'm very grateful for the acknowledgement. Um, Actually, like you said, the topic is very vast and wide. In fact, I had to like pick some, some very few aspects of it to make this presentation. So, of course, it would have been very nice to, summarize everything in a very, comprehensive, if, in a comprehensive way, so that people can have it as a take home. Thank you very much.
Yeah, thank you very much, Dr. Halimah, for the wonderful presentation. What I was going to say has been captured partly by Dr. Badamose is that communication in medical practice goes a long way in improving the quality of healthcare patients get to receive in the end. And the importance cannot be overemphasized. As much as we undoubtedly have the knowledge, medical knowledge, we need to improve on our ability to communicate effectively to patients. It might be worth taking some communication courses and learning how to appropriately send message across. So, and this is not a GP thing. This is not a matter of Faculty of General Practice is presenting. This is a skill that's needed across all specialties. Whatever we do as doctors, even in our general day life, effective communication is very, very important, and its importance cannot be overemphasized. I would just ask the speaker, how do we handle difficult patients? Thank you.
Okay. Actually, dealing with difficult patients is actually another, skill of consultation as well. I hadn't, gone into those other aspects because, like I said, quite a lot of skills are out there to improve our consultation. So, of course, effective communication is what is needed. Most of the patients are difficult initially because maybe they have some preformed mindset about either their condition or where they are coming. So, untangling some of those mindsets there and some of those misconceptions they have in a way that professionally will sometimes help to win them over, even though some of them are still very difficult, but it has been studied to be very effective when they tend to come around. Thank you very much.
Okay. Thank you very much. Thank you very much, Dr. Halimah. I also would like to say that communication is actually not the problem of family physicians alone or the general practitioners. It's actually the duty of every doctor. And it's a skill that we have been losing as the day goes by. As a radiologist, I've been seeing a lot of things, most especially in terms of requests. I'm at the diagnostic aspect of medicine. When you see some requests, you wonder if this doctor ever asked this patient anything. The request is so shallow, you can't make anything out of it. And it's obvious that the doctor does not show any concern. He just feels the person complains of headache, go and do MRI. And this headache might just be maybe from stress, so it's actually very important that we communicate. It's a bit difficult in Nigeria just because of the doctor to patients ratio. But that does not mean we should forget this important aspect of our practice. We are going to make this video and we're going to put it on our YouTube. And I want to implore everyone to watch it over and over so that we can remind ourselves of these tenets. So there's something I noticed about communication. It's something you develop, just like the quotes that Dr. Halimah mentioned during the presentation. It's not something you learn. It's something you develop over time. And I've seen it over time that the way I communicate, the way I talk to patients, in fact, if I'm scanning a patient and I explain what I saw on scan, some patients will tell me that they can now see clearer, because sometimes it looks like cloud to some people, but by the time I start pointing out some things to you, and by the time we finish, you two will be able to at least understand some things on the scanogram. So it's actually very, very important. So without wasting much time, I'm going to call on one of the top faculty members. We have a lot of them in the Faculty of Medicine. And Dr. Halimah, actually, your choosing you to present this topic was actually intentional. So it's not an accident. It's not by accident. We actually chose you, and for reasons that is best known to me and your faculty head. So I'm going to call on Dr. Farouk to give us closing remarks. Is the one that is bearing that chairman. So you can unmute your mic, chairman.
Thank you very much, Dr. Idris. Really appreciate your leadership. I want to appreciate everybody for coming around, for listening to this
So see the person that is saying I'm using glue.
I want to appreciate everybody for coming around, for listening to this presentation and being able to pick one or two things from this discussion. And I also want to appreciate Dr. Halimah for granting this request and taking us through communication skills. I want to appreciate all members of Faculty of Family Medicine and every other faculty as well for supporting us through this presentation. Thank you, everybody. Thank you very much. Just one comment about Dr. Abdul Karim, who asked about managing difficult patients. He's even in the best position to even answer the question, but we won't throw him into the spot tonight. So one way or the other, we'll be all about managing difficult. All right. Thank you very much.
Actually, we can actually create an inaugural lecture for Dr. Ahmed Abdul Karim. To actually, yes, it's going to be a topic on its own, managing difficult patients.
Exactly.
So, Dr. Abdul Karim, you should start your research. You can be called upon at any time to come and discuss with us.
It's all right.
So, okay. Thank you very much. Thank you very much, Dr. Farouk, for that closing remark. Once again, I want to appreciate Dr. Halimah for this wonderful presentation, and everyone that has made it to be part of this presentation. We are going to have another interesting one in August, and from this end, it's bye-bye for now.